ECG. Interpretation. Part 2. We will use these 9 steps to interpret ECG. Biodata. Includes patient's name, age, address, date, and time of ECG. These are important for identification of right patient. Rhythm. For detection of rhythm, we will observe the distance between P wave. Let's calculate it by using large box. One large box, 2 and 3 and some part of 4. Same distance between other P waves. Each P wave is approximately at a distance of 4 large box. So it is a regular rhythm. Irregular rhythms may be irregularly irregular, as in atrial fibrillation, and regularly irregular, as in second-degree heart block type 2. Rate. For regular rhythm, rate can be calculated by dividing 300 by number of large boxes between R to R. Let's calculate the rate between 2R. One large box, second and third and some part of 4. Dividing 300 by 4 we get 75, so the rate is 75 beats per minute. For irregular interval, rate can be calculated by number of R waves in 6 seconds. Now you will be thinking how to calculate 6 seconds, let's make it easy. If one large box is equal to 0.20 seconds, then 5 large box are equal to 1 second. And 30 large box are equal to 6 seconds. So you will have to calculate number R waves in 30 large box and multiply it with 10 to get irregular rate. Axis. Assume this axis, which includes 0, 90, and 180 degrees. Placing -30 between 0 and -90. From -30 to +90 its normal axis. From +90 to 180 right axis deviation. From -90 to -30 left axis deviation. And from 180 to -90 extreme axis deviation. Worrying about how to use this to interpret axis on ECG, let's make it simple. 2 methods are usually used. Quadrant method and isoelectric method. We will use quadrant method here. We will see upward or downward deflection of lead 1 and AVF to determine the axis. If upward are wave deflection in both the leads, it's a normal axis. Downward deflection in lead 1 and upward in AVF shows right axis deviation. Upward deflection in lead 1 and downward in AVF indicates left axis deviation. And downward deflection in both leads indicates extreme axis deviation. P wave. Usually it is 2.5 mm in height, which is in vertical direction, and 2.5 mm in length horizontally. Recall that one small box is equal to 1 mm. P wave may be absent in atrial fibrillation. P pulmonale height is greater than 3 mm occurs in right atrial hypertrophy. P mitral has notched P wave and occurs in left atrial hypertrophy. When both height and length are increased, it is called bifid P waves occurs in bilateral atrial enlargement. Flat P wave when height is less than 1 mm, it occurs in hyperkalemia. PR interval, which is a flat line between P wave and QRS complex. Usually it is 3 to 5 mm in length. Long PR interval occurs in heart block. Short PR interval with normal P wave is present in Wolff-Parkinson-White syndrome. And short PR interval with inverted P wave occurs in nodal rhythm. Depressed PR interval is present in pericarditis. QRS complex. Q wave is first downward deflection, R wave is first upward deflection, and S wave in second downward deflection. Its height is 15 mm and length is 2.5 mm. Broad QRS, in which length is increased, occurs in ventricular arrhythmias and bundle branch block. High voltage QRS complex, in which height is increased, occurs in ventricular hypertrophy. Low voltage, in which height is decreased and occurs in congestive cardiac failure and pericardial effusion. ST segment is a flat line between QRS complex and T wave. Always look for the ST segment elevation and depression as it is related to MI and ischemia. Elevation of 2 mm in chest leads and 1 mm in limb leads indicates MI, pericarditis, right bundle branch block, and depression indicates ischemia, posterior wall MI and left bundle branch block. For finding the site of infarction, we observe the leads in which elevation occurred. In anterior-occipital wall MIST, elevation occurs in lead V1 to V4 and it involves left anterior descending artery. In anterolateral MI, elevation occurs in V4 to V6 and in lead 1 and AVL. Artery involved is left anterior descending artery and circumflex artery. In inferior wall MI, elevation occurs in lead 2, 3 and AVF, and right coronary artery is involved. In posterior wall MI, tall T and R waves along with ST depression in V1 to V4, and the involved artery is posterior descending artery. T wave usually has a height of 5 mm and length 3 mm. Inverted T wave is seen in ischemia and MI. Tall and narrow T wave in hyperkalemia. Tall and broad T wave in MI before ST elevation. Flat T wave in hypokalemia. That's it for the video. We had discussed basics and interpretation, and we'll discuss some cases in part 3.